Hello and welcome to the Your Only Doc podcast. I am Dr. Shashank. Today we are diving into hyperosmolar, hyperglycemic state. Imagine it's late at night in the emergency room. A stretcher rushes past you with an elderly man. He's barely conscious, his lips are cracked, skin looks dry, and his heart is racing. The nurse shouts, "Blood sugar is over 800." But there's no fruity breath, no deep breathing like we see in diabetic ketoacidosis. His brain is starting to shut down. Stick around because we're about to dive deep into this dramatic complication of diabetes. Hyperosmolar hyperglycemic state, HHS, is a life-threatening diabetes emergency, usually in type 2. It occurs when blood sugar climbs extremely high, often above 600 milligrams per deciliter, without much acid buildup. The blood becomes very thick. HHS usually affects older diabetic patients who become dehydrated or ill. Infections, stroke, heart attack, or certain medications can trigger it. Patients with HHS become very sick. They may feel extremely thirsty and urinate a lot at first, then stop as dehydration worsens, which can lead to weakness, confusion, or even coma. On exam, we see dehydration, dry skin and mucous membranes, sunken eyes, and a rapid, weak pulse. Because some insulin is still present, these patients do not produce much acid or many ketones. Their blood pH stays near normal. Labs show extremely high glucose and osmolarity. Kidney function tests are usually very high from the dehydration. Aggressive fluid replacement. We start with large volumes of intravenous normal saline, about 1 liter per hour, to restore circulation. After initial fluids, we recheck labs. If sodium is high or normal, we switch to half normal saline for more free water. If sodium is low, we continue normal saline. Overall, the goal is to replace most of the fluid deficit in the first 12 to 24 hours. Next, we replace electrolytes, starting with potassium. Even if initial blood potassium is normal or high, total body potassium is very low. Once the patient makes urine, we give potassium. If serum potassium is below about 3.3 milliequivalents per liter, we delay insulin and replace potassium first. If potassium is not low, we still add potassium to the intravenous fluids to keep levels stable. We check electrolytes every few hours and correct them as needed. Then we give insulin to lower the sugar, but only after fluids. The typical approach is regular insulin by intravenous infusion. A common regimen is a 0.1 units per kilogram bolus, followed by a 0.1 units per kilogram per hour drip, or an infusion at 0.14 units per kilogram per hour without a bolus. The goal is a steady glucose fall of roughly 50 to 75 milligrams per deciliter per hour. When glucose falls to about 250 to 300 milligrams per deciliter, we add dextrose to the intravenous fluids so we can continue insulin without causing hypoglycemia. Throughout treatment, the patient is closely monitored in an intensive care setting. We check blood glucose and electrolytes frequently, about every hour, and continuously monitor blood pressure, heart rhythm, and mental status. We expect the patient's condition to improve as the dehydration and osmolarity correct. We also treat any underlying cause. When the patient can eat, we switch to subcutaneous insulin, usually restarting their long-acting insulin, basal, and giving short-acting insulin with meals. This concludes the basic management of HHS. Next, we'll move into advanced updates and controversies in HHS care. Fluid choice is hotly debated. Historically, we used normal saline, but studies now favor balanced solutions like lactated ringers or plasmolite, which may protect the kidneys and hasten recovery. The consensus suggests using balanced fluids when possible. In practice, we often start with normal saline and then switch to a balanced crystalloid once the patient stabilizes. With any fluid, we watch sodium and osmolarity closely, aiming for a gradual correction, not a big drop in sodium overnight. Insulin therapy has also evolved. The classic routine was a 0.1 unit per kilogram bolus and 0.1 unit per kilogram per hour infusion. Now, experts advise a gentler drip for HHS, about 0.05 units per kilogram per hour after the initial fluids. Some guidelines, like the British, emphasize correcting the volume first because starting insulin too early can cause a sudden blood pressure drop. The bottom line, we start insulin carefully only after the patient is adequately hydrated. One clinical pearl: continue the patient's usual long-acting insulin during the intravenous therapy. We often give their regular basal insulin dose even while on the drip. When stopping the drip, we start the next basal insulin dose 1 to 2 hours before ceasing intravenous insulin. This prevents the blood sugar from rebounding up. Other electrolytes get less attention. Phosphate and magnesium are often low, but we only replete them if levels are very low or if symptoms occur. Bicarbonate therapy is almost never needed. It's reserved for extreme acidosis pH less than 7, which virtually never happens in HHS. Not every HHS patient needs a continuous insulin infusion. If glucose levels are falling steadily after fluids and there's no acidosis, you might manage with subcutaneous insulin. But if the sugar remains very high or ketones appear, we switch to a drip. When infusing insulin, we target a modest glucose fall, about 40 to 80 milligrams per deciliter per hour. If glucose drops to around 180, we add dextrose to the intravenous fluids to avoid dropping it further that day. Another advanced tip: monitor the serum osmolarity. We want a slow, steady return to normal osmolarity. If osmolarity isn't falling, the patient needs more free water. For example, change to half normal saline or add dextrose. And we watch neurologic status closely, for any headache or confusion may mean we're correcting too fast. We have come to the end of this episode. On to the next challenge. We will dive into the tumor lysis syndrome. Make sure to like and follow us on LinkedIn, Instagram, Facebook, X, and YouTube to stay updated. And hey, if you enjoyed this, come say hi. You can find me on Instagram at @shashank_107. Drop a message, let me know you're listening, and share what you think. I would love to hear from you.